So a lot of you have asked, a lot of you may not know Mayo Clinic, Arizona, but it's actually a campus we're very proud of, and Axel is joining us as a chief of HEMONC. The top picture is actually our medical school, opened in 2017. First 50 students, ranked number 6 in the country, so doing great, the whole Mayo Clinic Medical School. And we have our research campus in Scottsdale, and the below is actually our hospital and cancer center, etc. I had to throw this in. So I actually think that the obvious has been already stated. And Hassan talked about a few studies, the Himalaya and others, that are comparing the experimental arms of immune therapy versus the standard of care, i.e. Sorafenib. So I could stop here, but I'm actually going to go through the discussion, talk a little bit about the TKIs first, followed by the experimental agent, albeit approved by the FDA. So this is the SHARP study. Again, I'm not going to go through the same slides, and you've seen the discussion regarding Lenvatinib. This was a non-inferiority study that did suggest that Lenvatinib and Sorafenib, well, Lenvatinib was non-inferior to Sorafenib. All what that means, essentially, it could be equally good, maybe a little bit worse, still within acceptable levels, and there's a very slight chance it may be superior, but overall, it's non-inferior. The Regorafenib study, the resource also was presented by Hassan. There was 11% response rate in the second line. You know, one thing we always hear about immune therapy is, well, you know, you may not affect the median as well, but there's that tail. There is a proportion of patients who benefit significantly from immune therapy, and that's about 20%. But I want to turn you here to the Regorafenib curve. Look at the 20% surviving beyond 26, 27 months. I mean, these are the curves you see with immune therapy, but just because Regorafenib is not immune therapy, or these TKIs are not immune therapy, we don't actually jump all over heels thinking that there is that subgroup of patients that just survives beyond 2 years. So just keep that in mind as we go through the discussion. Interestingly, in the RESORCE study, Sorafenib followed by Regorafenib sequence, essentially patients had a 26-month median survival versus those with Sorafenib followed by placebo. So when they looked at those patients who get exposed to the continuum of drugs, we're starting to talk about survival rates close to 2+ years with the sequence of Sorafenib versus Regorafenib. And then the study that was presented by Hassan, a great study, positive study, again, adding to our standards with Cabozantinib versus placebo in HCC. 100% of the patients had to progress to Sorafenib, and there were others as well, very few Regorafenib. And it was a positive study showing a good overall survival and a very good progression-free survival benefit with Cabozantinib versus placebo. So going back to CheckMate 040, this was, I remind you, a non-randomized phase 2 study, relatively large, addressed an interesting question, and essentially did show that there is a baseline of responders, investigator assessed, close to 20% for all patients. The survival, at least in the uninfected progressor, so these are the patients where you have the approval for, those that progressed on Sorafenib, was about 13 months, not much different from what we'd expect TKIs to do, and a progression-free survival of 4 months, which is really not fantastic. Now, Nivolumab seems to maintain then benefit post-Sorafenib. This is untreated, this is pre-treated. So, you know, whether you get exposed to Sorafenib or not doesn't seem to matter much to the activity of this agent. So making the argument that you should go first with it, again, based on phase 2 data, doesn't make a lot of sense. And I just want to show you all these, because we always like to dance around these waterfall plots. Anytime you want to show that an agent is, wow, incredible, you show a waterfall plot that just shows you, how it flips on one side versus the other. But I mean, look at all these waterfall plots. This is with Regorafenib, this is with Nivolumab, and this is with Lenvatinib, this is with Sorafenib. I mean, there's not much of a difference between all these waterfall plots. There's really not a strong case to be made for immune therapy yet. I think. So is this a new dawn for HCC with immune therapy? Is it reality or just too soon to tell? So let me guide you through a typical drug development process. And Dr. Abu Alfa has led a lot of phase 3 studies, had to go through a lot of the pains of going through a phase 1 to a phase 2 to a phase 3. That's how we develop drugs. We need a phase 3 because then it makes sense for us to adopt the medication or not. But let me expose you on how drug development happens in the immune therapy world. So you take a little bit of Kool-Aid, and we all drank a little bit of the immunotherapy Kool-Aid. You add to it a little bit of PD-1, and then you get an approval. That's all what you need. You don't need to go beyond through the drug development process as we typically do it for all others. So I'm going to take you through another example where we did the same. We had pembrolizumab in gastric cancer, Keynote-059. That's a fantastic swimmer's plot. Looks very exciting. It essentially led to an FDA approval. Very similar story. Phase 2 looks very promising, very interesting. However, this is what happened. The Keynote-061, which was pembrolizumab versus paclitaxel. Now remember, our standard is not paclitaxel. It's paclitaxel plus ramucirumab. So paclitaxel underperforms, negative. So the phase 2 led to an approval. The phase 3 suggested no improvement. So we need to take note of that when we're thinking about nivolumab in HCC the same way. So I'm going to conclude here and say how to best sequence patients with advanced disease. The good news is that we have a lot of options and a lot of emerging options. But we have only few phase 3 studies and few approvals to rely on. So if you look at first line, there's an ongoing phase 3 trial with nivolumab versus sorafenib, which may tell us a little bit more about the role of nivo in the first line, but we don't have that data yet. In second line, we do have pembrolizumab versus best supportive care. Ghassan showed you that data, that study. And so this is the landscape right now, and if you want to eliminate all the phase 3 studies. Now, mind you that the question marks, all the non-phase 3 studies, all the question marks are essentially FDA approval pending. And the little star is just, we're thinking about perhaps using this for patients who would never have any further options, including clinical trial. This is pretty much what you'll be left with. So Sorafenib, or Lenvatinib as an option in the first line when Lenvatinib gets approved. Second line, it's Regorafenib, possibly Cabozantinib, again, based on approval. And third line, again, Cabozantinib has both second and third line data. And then if all options run out, after all these multi-kinase inhibitors are done with, then you can consider a PD-1 inhibitor. So I think this continues to be a fluid situation. So I suggest everyone stays calm and wait for phase 3 studies to complete before we make a complete decision about what goes. Thank you.